COVID-19 has caused a global pandemic with over 25 million infections and approximately 1 million deaths. Patients with hypertension, diabetes, CKD, COPD, and those on chronic immunosuppressive therapy, such as solid organ transplant recipients, are at particular risk for developing severe COVID-19 pneumonia. Now, patients who are chronically immunosuppressed also are at risk for a variety of different opportunistic infections, including CMV. Our patient was 36 years old and had a renal transplant approximately 10 months prior to presentation. He was a male. He presented to an outside hospital with fever and acute hypoxic respiratory failure requiring high flow oxygen. His CMV serostatus was donor positive and recipient negative at the time of his transplantation. His maintenance immunosuppressants included cyclosporin and mycophenolate, and he was also on CMV prophylaxis with Ganciclovir. Now, on admission, he was treated for community-acquired pneumonia with ceftriaxone and azithromycin, and he was also treated for severe COVID-19 pneumonia with remdesivir, convalescent plasma, and dexamethasone. 2 weeks later, however, his respiratory failure had not improved. He was started on meropenem, vancomycin, and fluconazole, and also treated for PJP pneumonia, but 1 week after that, he had still not improved. He was then transferred to UTMB, where we noticed his CMV viral loads had increased more than tenfold over 1 month, despite being on prophylactic Ganciclovir. Now, given his high oxygen requirements, we could not pursue a bronchoscopy with biopsy for a tissue diagnosis. However, Ganciclovir-resistant CMV pneumonitis was at the top of our differential, given the fact that he had a pretty extensive negative infectious workup, as seen in the tables in our poster. He was started on high-dose Ganciclovir, and within 48 hours, his fever had resolved, and he was able to be solely weaned off oxygen. Within 2 weeks, he was able to be discharged home, not requiring any oxygen at all, any supplemental oxygen. Now, our case is quite unique. This is one of the first reports of co-infection of CMV pneumonia and COVID-19 pneumonia. In fact, just the literature on COVID-19 infections by themselves in renal transplant patients is quite sparse. Our patient has several risk factors for developing active CMV disease instead of just having an asymptomatic CMV infection. The fact that he was a CMV seronegative recipient of a seropositive donor is one of the primary reasons this happened. When you introduce an active infection into a patient and then blunt their immune system with chronic immunosuppressants, this is sometimes the result. Moreover, he also received 2 weeks of dexamethasone for his COVID-19 pneumonia, which further suppresses the immune system. Now, his CMV resistance panel showed a UL97C603W mutation, and this should be treated with foscarnet per guidelines. However, there has been literature that shows high-dose Ganciclovir can sometimes overcome CMV Ganciclovir-resistant CMV, and this was the case in our patient, and he clinically improved. While the gold standard for diagnosis is tissue biopsy, our patient was a crystal clear clinical diagnosis. He vastly improved after high-dose Ganciclovir was started. His CMV titers went down, and his infectious workup was otherwise negative. Thank you for listening to our presentation. I hope you enjoyed it.